Hello, my name is Benjamin King. I'm a fourth year medical student from Des Moines University. Thank you for joining me today. I'll be talking briefly about GAD, or Generalized Anxiety Disorder, what it is not, how it develops, who is at risk, and how we treat patients with GAD. So without further ado, let's get started. So the diagnostic criteria, excuse me, I think I missed a slide here. Yes. Um, let's start with the DSM-5. There's a lot of anxiety disorders that the DSM-5 includes, as listed here. It's more than 10. Obviously, we'll be just talking about generalized anxiety disorder, kind of really get into the nitty-gritty, hopefully, of what it is. Obviously, there's a lot here. The most common is actually like having a specific phobia. Generalized anxiety disorder comes in around third out of all of these. And at the bottom, you can see there are some delineations, some diagnoses that we can include if they don't fit perfectly into other boxes, such as other specified anxiety disorder or unspecified anxiety disorder. Let's see here. So the APA, Association of Psychiatry, first introduced the diagnosis of GAD in the 1980s with the DSM-3 and differentiated GAD from the diagnosis termed anxiety neurosis, which is now called panic disorder. Obviously, panic disorder and GAD is now generally well known to be a difference of symptoms and presentations, but at the time, just 45 years ago, it wasn't such. So we continue to differentiate these two. So the diagnostic criteria of GAD includes excessive worrying or anxiety causing significant distress in the person's life and occurs most days for at least 6 months. Um, this usually manifests in adulthood and has a chronic course leading to impairments in activities of daily living, diminished quality of life, and associated with high healthcare costs, especially due to the common delays in diagnosis. I use a mnemonic, worry warts, um, listed here, and they need to meet at least 3 of the 6 symptoms for adults and only 1 for children. These symptoms include worn out, which is the fatigue portion. They're wound up, they're irritable, very labile. They have absent-mindedness, so decreased concentration throughout the day. They're restless, they have tension in the muscles, often in the face, and they have sleep disturbances, whether or not that is difficulty getting to sleep, staying asleep, or the such. So they're often seen for symptoms of insomnia, and so proper diagnosis is crucial. So the symptoms are also not attributable to physiological effects of a substance or another medical condition, and these symptoms are better not explained by another medical um, or mental disorder, like such as panic attack, social phobia, OCD, PTSD. Patients often complain of somatic symptoms that are often nonspecific, including shortness of breath, palpitations, fatigability, headaches, dizziness, and restlessness. And then the psychological manifestation, they include excessive, nonspecific worrying, emotional liability, difficulty concentrating, and the insomnia which we discussed earlier. And I know I previously mentioned some diagnoses that can be ICD-10 diagnoses that can be prescribed or listed on a problem list for a patient. If they have most of these and they don't meet the full criteria for GAD, you can use other specified anxiety disorder or potentially adjustment disorder with anxiety if they experience a traumatic event and are also dealing in meet criteria for anxiety or GAD, but not quite, maybe not long enough, or maybe they don't have quite as many symptoms that they need to have for the duration that is laid out here. Something to be mindful of. So the etiology of GAD is multifactorial and not fully understood, but it's thought to involve biological factors, psychological factors, environmental and social factors. Within the biological factors, it is thought that neurotransmitter dysregulation plays a role. We see decreased GABA, gamma aminobutyric butyric acid. I messed that one up. I'll just say GABA. Decreased GABA, leading to excessive neuronal activity. Decreased serotonin dysregulation, which leads to disruption in mood and anxiety. And then we see an increased norepinephrine dysregulation, which leads to the heightened arousal in the patient. In the brain structure processing, this particularly is associated or involves the amygdala, which is known for the fear factor of the brain. And this leads to hyperactivity in response to perceived threats, as well as the prefrontal cortex, which we see inefficient regulation of the amygdala and emotional processing, kind of the control of the perceived threat isn't being suppressed adequately. There's genetic predispositions. The heritability is estimated to be around 30 to 40%, and family and twin studies show increased risk in first-degree relatives. Psychological factors include cognitive biases. So these patients often have intolerances to uncertainty. They have what we call catastrophizing, which is more simply laid out as a cognitive distortion characterized by exaggerating the potential negative consequences of events or situations, and then just the overestimation of threat. These patients can also have maladaptive coping mechanisms, so they avoid whatever may be triggering social interactions, the work responsibility. They are often reassurance seeking, and they excessively plan, which can reinforce the anxiety. Personality traits are involved. Patients with high levels of neuroticism, or patients that are very avoidant of harm. Again, that's just the hypervigilance that we see in patients with GAD. The environmental and social factors, early life stress, including childhood abuse, neglect, or overprotective parenting can contribute. And obviously chronic stress or trauma, so ongoing stressors, financial strain, illness, work stress, all of these can contribute. We see learning and modeling can also be a factor. Anxiety behaviors modeled by parents or caregivers can exacerbate GAD or even contribute to the development of GAD. This is when a child sees a parent worrying excessively. That could also be a factor in what we see in the heritability of it and how it kind of trends in family. So the epidemiology, there's a lot of people, it's a fairly common diagnosis, often with comorbidities such as depression. About 6.8 million adults are affected in the U.S. There's a 3.1% of the population, and an unfortunate statistic is that only 43.2% receive treatment. Women are at a higher likelihood of developing it. They have they're twice as likely to be affected. And the median age of onset is 30 years of age. However, it really can affect any person at any age. However, it tends to develop in early adulthood, around 18, 20. So let's move on here to the initial evaluation. So how do we evaluate a patient that comes in with symptoms and we, think they might meet the criteria? Well, first we got to make sure it's a primary cause. The primary cause is just defined as what you might think. It arises as a primary psychiatric disorder not caused by another condition or a substance. We commonly use the GAD-7 to assess the severity of the anxiety. One thing to be mindful of when we use the GAD is that it isn't, we assess severity based off of it, but it's really how often are these symptoms present, and they have less to do with maybe the severity. There's one question asking about affecting daily life, work, school, family life. That definitely gets into addressing the severity for sure. Other ones might be, they have it every day, but it's not debilitating. So definitely have to take into account some of the factors that GAD-7 assesses and doesn't assess. But it is a validated tool that we use to diagnose and also follow the management and treatment of GAD. With the patient, obviously you want to look at their past trauma, psychiatric history, and psychosocial stressors that may be contributing. Secondary causes are anxiety symptoms that mimic GAD, but are due to medical condition, substance use, or another psychiatric disorder. And in the clinic or the hospital, we often use thyroid function tests to assess for hypothyroidism or hyperthyroidism, probably more commonly, blood glucose levels, echocardiography to assess for structural integrity of the heart and any arrhythmias that may be present, and toxicology screen for any drugs that might be on board that may be contributing to the anxiety symptoms. So how do we treat a GAD? Well, it depends. Like I said, we use a GAD-7, and if a patient has mild GAD, often they might forego treatment. Obviously, it might not be recommended, but if it isn't at the level that they find would be worthy of finding treatment, obviously that's under the discretion of the patient, and that's where, as physicians um, um, or students, we need to have that discussion with the patient. But you can see the different severity levels: mild, moderate, and severe. 21 being the highest you can score on the GAD. Something that it also depends on the treatment is what's available. Is there someone that is available to do CBT, cognitive behavioral therapy, in your area? Obviously, some geographic locations might not have CBT available, and obviously, patient's preference, like we mentioned, is a major factor. So, UpToDate has a flowchart, and the first choice for treatment is cognitive behavioral therapy and/or an SSRI or SNRI. And these are serotonergic receptor inhibitors, and we need to look at the safety profile of these drugs to kind of pick, how do you pick out of all the SSRIs or SNRIs which one to choose, and it's based on safety profile and side effects. You might look at a family member of the patient who has GAD, and see if they've been treated adequately and effectively with medication in the past. That tends to be a great resource to have. It's likely that if a parent or a sibling also found benefit from a certain SSRI, that they might as well. And then an upcoming and currently researched tool to have in your bag is the pharmacogenetics, a study to look at how these patients metabolize certain drugs. So they look at the CYP450 enzymes, particularly the CYP2C19 and CYP2D6, to see how are these patients able to absorb, and how is the pharmacokinetics going to be impacted in this patient, which involves side effects that this patient might have and the efficacy of the drug for that patient. So these studies look at whether or not they're poor metabolizers, intermediate, normal metabolizers, whether or not they're rapid or ultra rapid metabolizers. Those are the categories. There's five different types of metabolizers. So if they are a poor metabolizer and they're CYP2C19, we look at medications that are metabolized by that CYP enzyme, citalopram, escitalopram, sertraline, for example. And if they're poor metabolizers, they might need a lower dose, a higher dose, and they might have more side effects as a result. And I did misspeak. That's a lower dose. So if they're poor metabolizers, the drug isn't going to be metabolized, and the side effect profile is going to be higher, and they're not going to have a great response to the medication. It's not going to have the effect that it would on someone who has a normal metabolite, who normally metabolizes that drug. And then CYP2D6, some medications that are metabolized with this enzyme: fluoxetine, paroxetine, venlafaxine, duloxetine. This is kind of something that many psychiatrists don't utilize, and there's reasons for that, whether or not insurance companies will pay for it, and really um, maybe some physicians don't have full confidence in the studies, but it's something to be aware of and something that may be hopefully more hopeful in the future and more accessible as well. So let me go back here. So the first um, choice, you choose an SSRI or an SNRI. And if there's no response, you're going to taper that first one and titrate to a second one. That's kind of the first step. If you do see a partial response, and remember that these SSRIs can take 4 to 6 weeks to have their full efficacy and working at full strength. If they have a partial response, you're going to start augmenting with buspirone or gabapentin or pregabalin. And then obviously if you switch to a different SRI because there is no response, and then you do get a partial response, then you augment once again. And if you do get full, if it's working well for the patient, you can continue treatment for a minimum of 12 months. If there's no response, you're going to stop that second SRI and use buspirone trial alone. And then it's a large flow chart. It kind of goes on to the next page. So treatment continued. Just a little bit about buspirone. It's a 5-HT1A partial agonist. Remember, 5-HT1A is an inhibitory serotonin receptor. They're located spatially, there's differences in spatial relationship and also temporal. So in time, there has been studies looking at how this affects different patients depending on age and also where these receptors are found. Gabapentin and pregabalin, these are alpha-2 delta subunits. They work on the alpha-2 delta subunit, which is a voltage-gated calcium channel. And they both work there. So they do not work on GABA receptors, some might think. And they work very similarly. However, pregabalin tends to have a more linear absorption, easier to titrate and dose, faster onset, more predictable dosing. But they both result in decreased calcium influx and decreased release of excitatory neurotransmitters such as glutamate, substance P, and norepinephrine, which is why it can be helpful in anxiety as well as often used for, think about seizure disorders and neuropathic pain. Looking at our flow chart, if we stop the augmentation agent and we look at whether or not they meet criteria for major depressive disorder, should we switch to atypical antidepressants such as vilazodone or mirtazapine? And then if there is no symptoms of that, you look at, is there a history of unhealthy alcohol use or substance use? We can look at using second-generation antipsychotics if they do have a history of such, or using hydroxyzine. Benzos are kind of the last line for GAD. It's high risks with using this medication. So we tend not to use this if we can avoid it, especially in the elderly population. And then if we continue, obviously, further down we really want to consider whether or not our diagnosis is correct if we continue to have treatment failure. The good news, GAD is treatable. So that's something that we need to remind our patients of. A lot of people, like we mentioned earlier, go untreated and they live their life in just this heightened, vigilant state. And obviously that takes a toll on quality of life and what you're able to do and how present you can be with the people around you. So it's really important to screen for this and diagnose it accurately and support your patients, especially as this treatment can take time. They can become discouraged. And as for all patients, we want to encourage a healthy lifestyle. All of these can contribute to and treat GAD as well. So including physical exercise, eating a healthy diet, maintaining social connections, and using meditation and mindfulness for these patients can be very helpful. Just got to be there for your patient and remind them and encourage them throughout this process, as it can be very lonely at times and very stressful for them. Here are my resources. I appreciate you listening to my presentation. I kept it brief. Hope I didn't belabor the point too much. Um, and we'll talk to you next time. Thank you.